السلام عليكم طلبتنا الأعزاء. أنا الدكتور عباس الموسوي، استشاري جراحة الدماغ والأعصاب والعمود الفقري، تدريسي في كلية طب حمورابي جامعة بابل. موضوع المحاضرة لهذا اليوم هو about the intracranial infection. The intracranial infection, first of all, we discuss what's called meningitis and ventriculitis. The meningitis describe inflammation of the meninges of the brain and the spinal cord, most commonly and most seriously due to bacterial infection. The community-acquired bacterial meningitis typically present with the fever, meningism, like headache, neck stiffness, photophobia, and deterioration in conscious level. The natural history involves a rapid progression to subpile encephalopathy, venous thrombosis, cerebral edema, and death. Therefore, empirical intravenous antibiotic therapy should be commenced as soon as the diagnosis is suspected. Urgent lumbar puncture is required to confirm the diagnosis and ultimately to guide treatment, since the differential diagnosis of this presentation include abscess, empyema, and subarachnoid hemorrhage. Initial CT imaging, where available immediately, is desirable to confirm that lumbar puncture is necessary, safe. The meningitis and ventriculitis improved mortality and the neurological outcome associated with administration of dexamethasone 0.15 mg per kg up to 10 mg 4 times daily for 4 days. The common organisms responsible for spontaneous bacterial meningitis are Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitidis. Neonates are susceptible to group B Streptococcus, Escherichia coli, and Listeria. Meningitis in the context of surgery typically follow a more insidious course but remain a field complication require prompt intervention. Typical organisms are Staphylococcus aureus, Enterobacteriaceae, Pseudomonas, and Pneumococci. The meningitis which occur after head injury is common, affecting 25% of patients with the base of the skull and the CSF leak. Repair of the CSF leak may be required, and the empirical antibiotic should have activity against commensal nasal organisms, including gram-positive cocci, gram-negative bacilli, in the presence of symptoms and signs of a clinical meningitis. Now we discuss what's called the ventriculitis, which refers to the infection of the ventricle, commonly as a complication of meningitis or due to contamination from a shunt or external drain. Where a drain is present, treatment may include administration of intrathecal antibiotic through it. Meningitis, in summary, it is a field complication of neurosurgery and head injury. Clinical diagnosis suspected by CT scan to exclude other pathology. CSF samples are taken for a glucose protein assay and for microscopy and culture. Treatment pending identification of an organism with the broad spectrum antibiotics. The second most important intracranial infection is brain abscess and empyema. Abscesses arise when the brain is exposed directly, for example, as a result of fracture or infection of the air sinus or at surgery. They also result from hematogenous spread, typically in association with respiratory and dental infection or endocarditis. In 25% of cases, no underlying primary infection is found, and the organisms involved are normally bacteria. Immune-compromised hosts, in particular, are vulnerable to a broad range of pathogens. We have a sinus mastoid infection, aerobe and anaerobic streptococci, hematogenous spread bacterioids and streptococci, penetrating trauma, Staphylococcus aureus, Clostridium, and Enterobacteria. Food contamination like Toxoplasma borg, tapeworm producing neurocysticercosis, immune compromised example HIV, AIDS, protozoal example Toxoplasma, fungal Cryptococcus, viral like multifocal leuko, encephalopathy, and mycobacterial abscess are encountered. In this brain CT scan, we see what's called early cerebritis occurring in the first 3 to 5 days, characterized by neutrophil infiltration, and this progressed to a late cerebritis with necrosis, edema, and macrophage recruitment by day 5 to 14. After this, the abscess is walled off by a developing green collagenous capsule which mature over the weeks and months. This is an axial computed tomogram scan with the contrast of a patient with frontal sinusitis and epilepsy, showing a hypodense area of cerebritis in the left frontal region. It's very obvious. The hypodensity indicating early cerebritis and it's coming from the frontal sinusitis. Diagnosis of brain abscess. The patient presents with a triad of features associated with the mass lesion. These are focal deficit, seizure, and raised ICB. A typical history might include fever, malaise, progressing over hours to days, to drowsiness and confusion, then focal weakness or seizure. A low-grade biopsy and equivocal blood marker of inflammation are typical. Blood culture should be obtained at an early stage, and the CT scan with contrast is the initial imaging modality of choice and will demonstrate a well-defined ring enhancement mass, that is to say, age enhances on the post-contrast image, typically with a thin small wall. The distinction between abscess and tumor can be difficult and has an important management implication since abscess generally require urgent drainage. MRI is a valuable tool in this context. The management of the brain abscess. The mainstay of the management is an early surgical drainage involving needle aspiration through a burr hole, with or without image guidance or by craniotomy. IV antibiotic therapy is then commenced using a broad-spectrum antibiotic, initially then turning to the sensitivity of organism culture. Treatment should be at least 6 weeks, but a switch to oral therapy may be appropriate after an interval and in consultation with microbiology. Up to 50% of patients with brain abscess will develop seizures at the same stage, so that prophylactic anti-epileptic should be considered. In this picture, we have a contrast CT scan of a patient 2 weeks later of the abscess. There is a ring-enhancing lesion. This is ring-enhancing lesion, typical of biogenic abscess, equal in the left frontal region. The presenting features are those of infection and of intracranial mass lesion. Imaging reveals a ring-enhancing lesion with tumor, usually the main differential diagnosis, and early diagnosis, usually followed by drainage, is key for good outcome. The right frontal lesion evident on T2. In this case, we have right frontal lesion. Exhibit a high signal on diffusion-weighted image MRI, indicative of restricted diffusion suggestive of brain abscess. The third one is subdural embolism, which refers to an infective collection of the subdural space and may develop as a result of sinusitis, mastoiditis, or meningitis. A subdural embolism associated with osteomyelitis of frontal bone, associated with scalp swelling and called Buffy tumor. An embolism, the pus will generally collect in the parafalcine region and over the convexity, triggering an inflammation and thrombosis. Presentation may mimic the meningitis and cerebral abscess. Typical CT scan are hypodense or isodense subdural collection with CT contrast at the margin, and the degree of swelling and midline shift. The embolism may be difficult to visualize, especially on non-contrast CT. Given the risk of herniation, the LB shunt should not be performed. Subdural embolism, craniotomy or craniectomy allow the drainage of the collection and relieve the raised ICB. We have subdural embolism in summary. Presenting features are similar to those of meningitis or cerebral abscess. It is a crescentic collection with contrast-enhancing rim is evident on CT. Drainage is the mainstay. In this picture, we have what's called a Buffy tumor, which is showing the osteomyelitis of the frontal bone from the right subdural embolism. The fourth one is tuberculosis, infection of the nervous system, which represent a hematogenous spread from the primary pulmonary foci. Tuberculosis meningitis, this commonly affected young children. CT will demonstrate intense meningeal enhancement, and the tuberculoma, it is like desiccated tumor at the base of the cerebral hemisphere, presenting with the mass effect. Tuberculous abscess seen predominantly in immune-compromised host, and this will represent progression of the tuberculoma with the prominent central caseating necrosis. Miliary tuberculosis describe a diffuse distribution of multiple small tuberculoma through the brain substance. Tuberculosis, where the meninges are involved, the lymphocyte can be expected to predominate in the CSF rather than polymorph that occur with other bacterial meningitis. The increase in protein content and reduction in glucose also less marked. Zium-Nielsen staining for mycobacteria is frequently negative, and polymerase PCR testing offer relatively rapid diagnosis compared to culture, and the management is with anti-tuberculous therapy. Hydrocephalus may require shunt insertion. And thank you for your listening to my lecture about the intracranial infection.